Excellent. Thank you, everybody, for your patience. I'm very happy now to kick off the proceedings. So first of all, I'll just introduce myself because you're going to have to bear with me for this session. I'm the Director of Programs at Unitaid, and I'm also the co-chair of the Global Oxygen Alliance. You'll hear from the other co-chair, David Lawrence, later in the program. So I have the distinct honor of being your master of ceremonies for today. And I'm not the one doing the welcoming remarks, so I'm not going to take much longer than I am now because people are on a tight schedule. So what I'm going to do is, first of all, thank you to the Mission of Kenya, to the Government of Kenya for hosting this excellent meeting, and hand over to the official welcome that will come from Dr. Patrick Amoth, who's the Director General of Health at the Ministry of Health of Kenya. Dr. Amoth serves in this capacity and previously headed the Directorate of Public Health, where he spearheaded strategy development for effective delivery of health services in Kenya. Among his extensive experience, he has also served as the Medical Superintendent in the Kiambu District Hospital and served as the District Medical Officer of Health for Kiambu County. You'll also be pleased to know, and many of us in this room know, he was also once the chair of the WHO Executive Board. So, Dr. Amoth, Professor Amoth, without further ado, I hand over to you to give us the welcome remarks. Thank you.
Thank you, Robert, and thank you for giving me a new title of a professor. Your Excellency Nahumicha Susan Wafula, Cabinet Secretary for Health of the Republic of Kenya, Dr. Philip Duneton, Executive Director, Unitaid, Your Excellency Dr. Frank Anthony, Minister of Health of Guyana, ambassadors and permanent representatives from Geneva-based missions, Dr. Mike Ryan, Deputy Director General and Executive Director, WHO Health Emergencies Program, Mr. Peter Sands, Executive Director, the Global Fund to Fight AIDS, TB, and Malaria. Ladies and gentlemen, good evening. On behalf of the Government of Kenya, I'm delighted to welcome you to the Kenya Mission for an evening discussion that highlights the importance of one of the most neglected medicines in the world, which was brought to the fore during the response to the COVID-19 pandemic. Oxygen is an essential medicine used to care for patients at all levels of the healthcare system, including in surgery, trauma, critical care, and various infections. Kenya is therefore pleased to be co-hosting this event with goal partners Unitaid, Africa CDC, the Global Fund, PAHO, and UNICEF. During such a busy assembly, we appreciate each one of you taking your time to come join us and share your reflections on this important issue. This evening, we will get to hear more about how different public-private partnership models are being deployed to address this issue and to ensure that oxygen access is guaranteed for everyone, everywhere who needs it. Through our discussions, we shall be able to appreciate the great progress made under the Goal Partnership since its launch at the World Health Assembly last year. With those few remarks, it is now my honor and pleasure to invite the Cabinet Secretary for Health for the Republic of Kenya, Madam Nahumicha Susan Wafula, to make her remarks.
Thank you, DG, Your Excellencies, Ministers, Ambassadors present, heads of agencies, distinguished guests, ladies and gentlemen, and as we say in Kenya, all protocols observed. I am delighted to join you this evening during this high-level side event for increasing access to medical oxygen local to global efforts. Medical oxygen, as has been said by the DG, is a life-saving and essential health commodity, which I note that has no substitute that is used in the management of health conditions, especially those requiring breathing support. It is an essential commodity which makes a life and death difference for mothers, for babies, and any other person in need of medical, surgical, and obstetric emergency care. Availability of quality medical oxygen is often a challenge In many low and middle income countries, with the situation getting more acute at primary healthcare level, where less than 50% of health facilities have uninterrupted access to oxygen. The government of Kenya is committed to realization of universal health coverage that will ensure provision of quality essential health services without financial hardship to all Kenyans. Therefore, availability of quality medical oxygen is a critical enabler of the right to quality health care through building resilience of health systems. In 2019, the Ministry of Health first listed medical oxygen as an essential medicine to enable focus on availability and quality, bearing in mind the critical role it plays in management of various emergencies. During COVID-19 and post-COVID, the Ministry of Health, in partnership with stakeholders, established oxygen generating plants installed in major referral hospitals to improve oxygen generation and self-reliance. Bulk liquid oxygen tanks were installed to enhance capacity for storage in selected COVID-19 centers. Resources were also set aside to procure more oxygen in cylinders, and there were investments in diagnostic tools such as pulse oximeters and vital sign monitors. Looking ahead, allow me now to highlight just some of the ongoing and future investments in this area. First, the government has procured over 20,000 oxygen cylinders with the support of the Global Fund. These cylinders were flagged off and distributed to all 47 counties in 2023, and I remember this function very well. It was flagged off by His Excellency the President, and I think Lyndon Morrison from Global Fund was there with us on that day. And I'm not sure if our governors are here, they would remember because we invited all of them. Secondly, we intend to procure and install pressure swing adoption oxygen plants to benefit 27 health facilities in 10 hard-to-reach counties, and this represents 66% of the need. Of this, the Global Fund procurement of 2022 is ongoing, while 5 supported by USAID are already installed. To increase storage capacity, we plan to install 21 bulk liquid oxygen storage tanks with the support of Global Fund and Clinton Health Access Initiative. There is also an ongoing installation of manifolds and piping infrastructure in 326 health facilities to improve storage and delivery of oxygen. Additionally, there is an ongoing procurement of other equipment and accessories for oxygen delivery. Lastly, the development of guidelines on management of medical oxygen, addressing all aspects of production, storage, delivery, use, quality assurance, and monitoring. In conclusion, I wish to reiterate that Kenya values the efforts of the Global Oxygen Alliance partners to continuously improve access to quality medical oxygen. We look forward to continued engagement with you as you complement the efforts of government, private sector, and other players in ensuring equitable access to quality medical oxygen for all Kenyans. And allow me to also say welcome to our home while we are here in Geneva. Feel at home. Thank you.
Thank you very much, Honorable Minister, for those opening remarks and for your warm welcome. And we thank the government of Kenya for the leadership it's showing in access to oxygen in Kenya and in the region. It gives me great pleasure, and we've made a small change to the program to bring the Minister of Health of Guyana before Dr. Mike Ryan, given that he has a pressing commitment to leave to after this. But it gives me great pleasure to invite the Honorable Dr. Frank Anthony, the Minister of Health of Guyana, to come and speak to us. Dr. Anthony has been practicing medicine in Guyana since 1993 and has served as the Director of Health Sector Development before his ministerial duties, and also been playing an instrumental role in reorganizing the health sector in his country. He's also taught at the University of Guyana and as an adjunct professor of public health at that time, also a professor. He brings many years of also parliamentary experience, including serving as Guyana's Minister of Culture, Youth and Sports. So it's with great pleasure, Dr. Anthony, we ask you to come up and give us your perspective from a country perspective on building stronger oxygen ecosystems. Thank you.
Thank you very much, Mr. Chairman, Madam Minister of Kenya, other distinguished ladies and gentlemen. First of all, I want to say that it's a pleasure being here with you this afternoon. And I want to say that oxygen, nobody thinks about oxygen as medicine in a very formal way. And this has been an area that I think has been quite neglected across the developing world. During COVID, I took over as the Minister of Health in August 2020. And we had our first case of COVID on the 11th of March 2020. But when we came into office, when I took over that office, one of the things that I quickly realized, we didn't have the capacity to make diagnosis. So we didn't have the means of doing that. And actually what we had to do was to repurpose an old machine that we had to be able to do the diagnosis for COVID. And worse yet, none of our wards in the hospitals were geared to treat patients with COVID because we didn't have isolation units. And in fact, we had to shut down the main hospital to allow for COVID patients to go there. We quickly then set up a separate facility so that we can isolate patients who needed hospitalization in a different facility. But even in that different facility, we didn't have enough oxygen for our patients. And our big challenge was, how do we get oxygen to this facility? We were bringing them in huge tanks, stacking them in a separate room, and then trying to get it into the rooms of the different patients. And every time someone, like every hour, would have to go and check the tanks to make sure that the tanks were still, they had enough oxygen, because we didn't have the meters to actually check whether or not, what was the flow and all of that. And that brought home the realization of how important this is. Eventually, we were able to put in bulk tanks for this particular hospital, because this was where we had most of our patients, and try to build wards and to make sure that we had adequate tanks to supply the oxygen for these areas. And so we were trying to build capacity during this pandemic. And I don't think that should happen to any country for future pandemics, because this is very important. Then in Guyana, we have the coastal areas and we have very rural areas. And they're very hard to reach, very difficult to reach. And I guess for most developing countries, you have similar challenges that we have. And so if you have to take, because the oxygen is manufactured in Georgetown, and if you have to take it 600 kilometers away, you have to pay for transport, you have to take it in, and then you have to install it, and that's an ongoing process. Our territory is very diverse. You have lots of rivers and all kinds of challenges. And so that became very problematic. We got 2 small oxygen well, not small, but relatively big ones, oxygen concentrators that we have put in 2 of these rural hospitals. And I was very proud that we are now able at these hospitals to manufacture oxygen on site. So whenever we need oxygen for that particular hospital, we were able to do it. But we haven't been able to cover all of the hospitals that we have and all these rural communities that we have. So we still have many gaps. And I'm very hopeful that the spotlight that this alliance is putting on the need for oxygen and the need for us to develop this capacity and the need for funding, that we will truly mainstream this and be able to attract the funding that it deserves, because this literally can save people's lives. And I think that that is so important. I also learned another thing, and that's one, I'm very happy that I came. I met 2 gentlemen at the back And, well, one is sitting here. And so I just learned that the Global Fund is actually funding oxygen, and they're in 59 countries. So I'll be having another conversation with them to see how we can get them to Guyana. But thank you very much for having me. I'm sorry I have to go because I have a meeting at the main office there. So I have to leave you. But thank you so much for having me.
Thank you so much, Dr. Anthony, and we really appreciate making the time. We now have the honor of inviting Dr. Mike Ryan up to the stage to make his opening remarks for us. I will keep a brief bio of Dr. Ryan, even though it's long. We know he was recently appointed the Deputy Director General for WHO, but he continues to serve as the Executive Director of WHO's Health Emergencies Program and leads the response to disease outbreaks at WHO, as well as other humanitarian crises and public health emergencies. Dr. Ryan, even though he doesn't look it, joined WHO in 1996, but he still looks like a spring chicken. I will just leave it at that because we know how extensive Dr. Ryan's commitment to service in public health has been, and we really want to listen to his framing remarks on this critical topic of oxygen. Dr. Ryan.
Asante sana. Jambo, everybody. It's good to be here at the Kenyan mission. Asante kwa ikarumu wako, it says that. And I say that because my formative medical experiences were in Kenya, in West Pokot and Kapunguria. So I saw wonderful health workers. Mainly the clinical officers and the nurses taught me everything that I know about medicine. And those of you who've worked in that situation will recognize that. But also saw the value of the presence and the absence of medical oxygen at critical times. So it's not something we in the health, we take it for granted. People working in the developed country situations take the presence of oxygen for granted. The minister said we see it as a medicine as such. But we just take it for granted. It's hanging up over everyone's bed. We just got to find the right mask and stick it on the patient. And for that critical period in their illness, when their blood oxygen drops, they're able to be tided over until their body can recover, or the antibiotics can work, or the blood replacement therapy can work. Oxygen is one of those therapies that gets you through the worst moment in your life or the worst moment in your child's life. And it is so simple. Unless it's not there. And then you lose patients because you simply do not have medical oxygen. And that is the greatest tragedy a health worker will ever face. Knowing you're doing everything right. You've managed to find the antibiotics. You've managed to stabilize the bleeding. You've managed to do all those things, and the patient just needs medical oxygen to get them through the next 12 hours. And you just don't have it, and you lose the patient. And that's been the experience of many health workers around the world over many, many years. The problem in COVID is it happened everywhere. It happened every minute of every day for months and months and months and months. And we were faced with the inadequacy of our system. Years of poor planning, decades of non-investment, ignoring a problem that was right in front of our faces. Having lost pregnant women, malaria patients, TB patients over many, many years, we just started to lose everyone else in the middle of this crisis. And all of a sudden, it's become a major issue. Having said that, I really want to recognize the work that everyone has done in this room, our partners, particularly in Unitaid, for taking up the challenge here, our colleagues at the Global Fund, at UNICEF, and all the other partners who we work with in the Global Oxygen Alliance. Because and the countries who've championed this cause. We're doing our piece in trying to increase access to medical oxygen. We worked hard during the pandemic. I'd like to recognize the presence of Janet Diaz, a physician who I admire greatly and leads our clinical programs with WHO. There's no one who's fought more bravely on the front line of epidemic response than Janet. And she's passionate about this. And if I had refused to show up here, I would have been dragged here by my neck. So we have a passionate crew at WHO who really believe in this. And it's not just medics. there are engineers, there are biochemists, there are so many different people, and I think it really illustrates what oxygen is about. Oxygen is an ecosystem of production, an ecosystem of supply, an ecosystem of good manufacturing practice, an ecosystem of logistics and equipment and machines that work when you turn them on, and machines that are serviced regularly. It requires good roads. It requires a truck that works. It requires all the things that you want to see happen. The oxygen itself is a commodity within an ecosystem, a quality managed system that allows oxygen to be there when it's needed. So we can't just buy the cylinders and think we're done. There's a whole process to put in place, and that's why it really does need a multidisciplinary approach. We've had and thanks to government of Senegal and Dakar, we had a very successful meeting a couple of weeks ago. It was a couple of weeks ago now, it feels like months ago at this stage. But on the road to oxygen access, on the framework, and pulling that together with 63 member states and 70 partners and the gold partners in there, it's a big step forward because it really puts this thing on the road to practical reality. And we're working hard to finalize that template, which will be used as a national oxygen scale-up template. In other words, a roadmap for countries to go on that journey and sustain that journey over time. Many countries are ahead. Kenya and others had to solve their own problems. Somalia and other countries had to solve their own problems. They had to build an oxygen infrastructure. For example, Somalia is a good example. There was no oxygen infrastructure. Didn't exist in Somalia, and it's built. Our problem now in many countries is we're losing that infrastructure, diagnostic infrastructure, therapeutic infrastructure, because we saw a fiscal expansion during COVID. I'm sure the chief in Kenya knows that. The checkbooks were open for the health programs. Now the finance ministers are back. And they're back to collect. And what we're actually seeing is a fiscal contraction in the health system. And you can imagine looking at oxygen and you say, okay, it's not a medicine. It's expensive. It requires infrastructure and maintenance. You can imagine being the Minister of Health. You're looking at that and all you're seeing is dollar bills, dollar bills, dollar bills. They don't necessarily see the life saved. They see complexity and they see long-term commitment. That means cash, money all the time, forevermore. And we have to put oxygen at the center of the health agenda, the health planning cycle. It can't be just a once-off thing that we do when we have a crisis. It's got to be integrated into the whole health policy and planning cycle and given the prominence that it deserves. And that advocacy is something that everyone at this table is doing. We need norms and standards. We need good manufacturing practice. We need manufacturers to produce high quality product. We don't want to spend our time producing new product and then find we're killing patients with a bad or toxic product. And we thank our colleagues in our sister program, and they're here with us today, who are really driving this inside WHO as a quality management system and GMP and all those things. We're just I suppose the medical techs on our side, but there's a huge amount of work going on to get that right and get the GMPs established for medical gases, getting the tech specs done and making sure all of that works across the world in a standardized way. We're all lacking investment in that, investment in the infrastructure at country level. But I think it's a really good investment. This is a low-hanging fruit for any medical system to be able to demonstrate that it can give oxygen when needed. And we also need to inform our decision-making with evidence. There are good examples, anecdotal examples of what's happening, but we don't have a formal monitoring system for this. I couldn't tell you today who has what, where, when, what stage they are in the process, what it's costing. So we're going to need performance indicators for oxygen management so we can track what's happening, who's doing what, where. And most importantly, we're going to need human resources for this. Not just medics and nurses and physios who can use oxygen, but the people who make that oxygen usable and available, and recognize that there's a broader human health workforce that's needed to sustain the oxygen supply. So full commitment from WHO. Huge amount of thanks to the co-chairs, Unitaid and the Global Fund in the whole alliance, the vice chairs, Africa CDC and PAHO, and Unitaid, UNICEF, and our colleagues at WHO who formed the Secretariat for this wonderful program. This is one of the best news stories. This is about saving lives in real time. And anyone who's ever been a physician and seeing what the difference it makes when you put an oxygen mask on a patient who's blue and you watch them change color, you'll know how important oxygen is. Thank you.
Thank you so much, Mike Ryan, for laying it down as it is. And we thank you also so much for your leadership, not just on this issue of oxygen, but over all the years when it's come to pandemic response and outbreak response and your commitment to that. And we're very privileged to have a leader like you working and supporting this alliance and the work that we're doing. The last speaker before the second session, which will be on the Global Oxygen Alliance and its strategy and efforts to continue carrying this torch and driving oxygen access, is His Excellency Mr. Atsuyuki Oike, who's the Ambassador and Permanent Representative of Japan to the UN Office and other international organizations in Geneva. And it brings me great pleasure to invite the Ambassador up here to speak. He is served as the permanent delegate of Japan to UNESCO before this role, and has been a career diplomat at the Ministry of Foreign Affairs of Japan and held several prominent roles in trade and international cooperation. Japan has been an incredible supporter and funder, not just in international development, but during the ACT-A response, and also for oxygen efforts during that time through many partners, including Unitaid. Thank you, Ambassador.
Good evening, Minister Fura and the Kenyan delegation. Thank you very much for organizing this event. I'm a diplomat, and I'm not a medical doctor, but I can understand the importance of medical oxygen from my experience in COVID time. It was not just the developing countries, also developed countries like Japan, which had a serious oxygen problem. Everyone was running around to look for oxygen. I still have a vivid memory of that. So I have no doubt about the importance of medical oxygen. By the way, Japan has been a great supporter of what is called a universal health coverage for quite a long time, since the year 2000. Since the year 2000. We have been advocating this in many different fora. It's United Nations, UNGA in particular, and also G7 and G20 fora. Everywhere we have advocated this, and medical oxygen is indeed one very important component in our initiative. And for that reason, I'm very happy to be here on this occasion. Now, maybe the reason why I'm here is that Japan contributed $7.3 million this year to a project called Medical Oxygen Regional Manufacturing Expansion for Africa, also known as More for Africa. You have two between in the middle of more. That is a project name. And obviously, this funding will support the activities to expand the access to medical oxygen in East Africa, and will help advance the supply of critical medical countermeasures. Medical oxygen is indispensable for everyday functioning of a health system and the achievement of universal health coverage. That is a point that I wanted to make. To achieve the universal health coverage, medical oxygen is a very basic and important part. That's the point that I wanted to make here. Now, furthermore, the future likelihood of high-risk pathogen causing respiratory, sorry, you can understand I'm a diplomat, not a doctor. So respiratory infections underscores the need to urgently invest in scalable, sustainable access to oxygen in low and middle income countries. Effective oxygen system strengthening the effective oxygen system strengthening requires a systems approach addressing challenges to oxygen supply and distribution, as well as the service delivery on how it is used for patients. Building more sustainable and robust oxygen ecosystem will be crucial to realize universal health coverage and pandemic preparedness and response goals. This requires close cooperation from the entire international community. Japan is committed to continue leading and working through international cooperation to improve access to medical oxygen, strengthening health systems, and achieving universal health coverage. This is the basic policy from our perspective. So we appreciate the efforts by Unitaid and also the Global Fund. We are one of the major partners of the Global Fund. I'm very happy that Global Fund is very active in this area, as well as Unitaid. Thank you very much.
Thank you very much, Ambassador Oike, and thank you, Mike, and good luck with the rest of the assembly as you go to your other commitments. So thank you, Ambassador Oike, and thank you for, again, all the support, financial and otherwise, that Japan has put towards this critical issue, and also others in the development space. So the Ambassador of Canada, Ambassador Leslie Nord, is not able to join us in the end today, but I do want to acknowledge also Canada's incredible support to the Access to COVID Tools Accelerator response, including oxygen, over the past 4 years, and their continued commitment moving forward as we convert the COVID response now to a sustained response for oxygen. And Canada has been incredibly generous in committing $16.9 million to Unitaid to continue those efforts over the next 3 years. So we want to acknowledge those efforts and the Ambassador's personal commitment as well. That brings us to the end of the first part of the session, and we're bang on time, more or less. No credit to me, credit to our speakers for being direct and concise, but conveying the messages they did. So now we're going to move into the second part of the session, and this is going to be about what the Global Oxygen Alliance is actually doing now, 1 year in. You'll remember the Global Oxygen Alliance was launched a year ago, this time during the World Health Assembly. And we're going to hear from different members of the Alliance about the progress we're making, but the work we still need to do moving forward. And it brings me great pleasure to invite my co-chair of the Alliance, Dr. David Lawrence, to come up and kick us off with that session. So let me say a few words about Dave, as we affectionately call him. So apart from being our co-chair and a real strong advocate for the work we do at GOAL and Access to Oxygen, Dave is a senior advisor at the Global Fund and a team lead for pandemic preparedness and response, and a strong personal advocate and committed fighter for this critical thing we call access to oxygen. So Dave, over to you to kick off this next session.
Thank you very much, Robert. Good evening, everyone, and all protocols observed. So as GOAL co-chair, my role here is to set the stage for the session. I'm going to provide a quick recap of GOAL's origins, progress over the past year, and the current outlook for 2024 and moving forward. So GOAL was born from the ACT-A Emergency Oxygen Taskforce, which was established in the peak period of crisis during the COVID pandemic in the spring of 2021. And the Emergency Oxygen Taskforce had many achievements, but there were three principal efforts. One, to mobilize roughly $1 billion in new funding for medical oxygen systems. Two, to address shortfalls and gaps in supply, particularly with a focus on bulk oxygen production. And thirdly, provision and coordination of technical support to over 100 countries who were real-time looking to assess their oxygen systems, to develop strategic operational plans, to develop and review funding requests to support their national COVID response plans. So there were 5 essential pivots in this moment where GOAL was launched and the sort of baton was passed from the Emergency Oxygen Task Force roughly 1 year ago. First and foremost, there was a shift from focus on capital investments to implementation and operations. There was a move away from product-specific focus to a more holistic, cross-cutting and health systems emphasis. There was also a shift from the ad hoc approach. People were learning how to do these things real time to a more mature, inclusive and planned approach. Pardon me. There was, of course, a primary reference initially to the national COVID response plans. And in lieu of that, we've heard already references to this really important WHO-led meeting 2 weeks back in Dakar on oxygen roadmaps. And goals focus is really on plans that are anchored deeply to the health sector plans of countries, reflecting UHC primary healthcare, PPR needs, and fundamentally the oxygen roadmaps. And then I think some of our colleagues from the advocacy working group who are here will appreciate this, but we had oxygen in the headlines. It was capturing everyone's attention for all the wrong reasons. And now we are fighting, and our advocacy working group colleagues are fighting admirably to keep oxygen in the headlines for the right reasons. So, pardon me, the goal really represents an unprecedented convening of diverse stakeholders in oxygen, from countries to donor, technical, implementing, advocacy partners, with a single goal to leverage expertise and to drive forward expansion of access to oxygen in low and middle income countries. The governance structure is intended to be streamlined and agile, a light touch conception with co-chairs, vice chairs, a secretariat, and the engine of goal, the task force, constituted by 4 fit-for-purpose working groups, and some additional flexibility to identify and constitute advisory groups, stakeholder engagement groups, where appropriate, very deliberate and ongoing collaboration with the Lancet Medical Oxygen Commission. And I would call out the intent to constitute a Ministry of Health advisory group, something that was taken up with a lot of positive energy at the roadmap meeting. And this will be the first fit-for-purpose advisory group, which will accompany the development of the full goal strategy and investment case, which is to happen later this year. There we go. So quick recap. I mentioned the task force, the 4 principal working groups that are driving the progress and goal. First and foremost, focusing on the consolidation of existing investments and a turn to thinking about sustainability, implications for domestic resource mobilization, the ongoing work, innovation, focusing on supply chain, market shaping. Working group 3, the country-focused planning and implementation, principally the WHO-led work on the roadmap, guidance and tools, and again, critically, the advocacy working group focusing on on demand generation, and then in the middle, this cross-cutting group focusing on performance measurement and accountability. And the last slide, I believe, before I turn it over. This graphic really captures, again, in the pandemic period, the roughly $1 billion in investments in oxygen, again, unprecedented. And the emphasis you'll see on the capital investments focused on bulk oxygen production. And what is envisioned in, and this is drawn from the executive summary of the goal strategy that was launched at UNGA last year. You'll see that for the current period leading up to the SDGs, what is anticipated is certainly a larger target for resource mobilization. That target will be modified through the process of the current year and the more stringent due diligence that's going to be brought to bear on that. But the key thing here is this hydraulic shift towards focus more on the systems, the workforce, all of the other elements of the ecosystems that we heard Dr. Ryan and Minister Anthony speak of earlier, and others speak of earlier. And I think that's the critical context. Robert, I'll turn it back to you. Thank you.
Thank you very much, Dave. And that gives us an excellent segue to our next speaker. We've ended on financing, which is going to be a critical pillar of oxygen access moving forward, which is why it gives me great pleasure to introduce the Executive Director of the Global Fund, Peter Sands, to speak. The Global Fund co-chairs GOAL, as you've heard, and the Global Fund as the largest grant financing agency for oxygen during COVID, and we hope moving forward needs to be applauded for how they stood up to this response. So we're going to hear from Peter, who, as you know, is the Executive Director of the Global Fund, but I'll say a word or two about his past lives. He is a former Chief Executive Officer of Standard Chartered PLC and was a research fellow at Harvard University, focusing on financial markets and regulation, as well as other things. And before then, he also chaired the US National Academy of Medicine's Commission on Global Health Risk Frameworks for the Future and the World Bank's International Working Group on Financing Preparedness. So Peter, without further ado, over to you.
Thanks, Robert. I always hate it when I hear somebody say, and now we're going to talk about money, and they start looking at me. This is the trouble with having been a banker and then gone into the world of global health, I think. But first of all, my thanks to the ambassador and to the government of Kenya for your leadership and for hosting us here. And it's great to see all of you. I basically have just 4 points to make. First point is COVID-19 exposed some harsh, deep inequities in global health. And one of the ones that was most striking and deadly was the fact that so many parts of the world simply didn't have any capacity to give people oxygen. And a shocking number of people died who didn't need to die because they didn't have oxygen. And that was the trigger for what we are now doing now, the realization that actually we had a big hole in healthcare provision in too many parts of the world. What we also discovered is that discovering that in the middle of a pandemic is too late, because while you can do some things with the canisters, you simply can't manage the scale of provision that's required through canisters. You need bulk oxygen provision, and you can't get canisters everywhere. The second thing, my second point, is that improving access to medical oxygen is from, and I'm now talking not as a clinician or a scientist, there are many more people, not least Philippe, who knows so much more about this than I, but as an economist and banker. If you do the math, this is a no-brainer investment, absolute no-brainer investment. If you look at it from a pandemic preparedness perspective, most of the threats are respiratory threats. And therefore, if you want to save lives from new pandemic threats, having oxygen capacity is a critical tool. But what makes it an even better investment is it's not like some things you do for pandemic preparedness, which are not that useful when you don't have a pandemic. The great thing about medical oxygen is that it also saves a huge number of lives when you don't have a pandemic. I have been to a number of countries which have already installed PSA plants financed through C19RM, the Global Fund's COVID response mechanism. And I always ask, so what's the oxygen being used for? You know, what's the stats on what you've used it for? Maternal health. A lot of maternal mortality can be reduced by provision of medical oxygen. Acute trauma. Traffic accidents, a lot of people die who, if you had oxygen, you could keep them alive. And a whole range of general surgical applications, which frankly, many of them aren't possible if you don't have oxygen. And so, as I say, it's a no-brainer investment because it protects you when you're threatened by a pandemic, but it also saves lives when you're not threatened by a pandemic. So that's my second point. The third point is that I think any of you who've been involved in any of the implementation projects will have discovered that actually implementing sustainable oxygen provision is pretty complicated. The technology is pretty complicated for producing bulk oxygen. The civil engineering is quite complicated. And then the actual delivery to patients requires training and point of care systems and equipment, depending on what particular use case you have. And so it's not being trivial. And that's another reason for not trying to do it in the middle of a pandemic, but to do it before you get hit by a pandemic. And that is also why I think it's been great that a year ago, we created this alliance and, as David just said, shifted the focus towards the implementation side of it so that we could work together to ensure effective implementation of these projects. And this is unprecedented in scale. We alone have invested, are in the process of investing over 600 million. It's roughly about $600 million in oxygen provision, with a big share of that in Africa. And I'm pretty sure that this is going to be the biggest step change in the provision of medical oxygen in Africa that the continent has ever seen. And that, I think, is something that this group of people should feel very, very proud of. But then we come to my last and final point, which is that given that we have made this step change, we cannot afford not to build on it, to make it sustainable. And also, now that we've proven it's such a powerful way of improving healthcare and saving lives, that we make access to it even more widely available. Yes, there's a shift. There'll be somewhat less capital, more systems and processes, but we need to continue to expand the reach as well as just ensuring that those investments we've made, those investments we've made, are sustained, maintained, and fully utilized. That will take money. I'm not promising all of it from us. It all depends on the generosity of our donors, and I have to appreciate Japan's support of consistent and very high level of support of the Global Fund for many years. But between us, we're going to have to find ways of continuing to increase investment in oxygen. And yes, we will play our part, but I think governments are also going to have to put lines in their budget for this, because ultimately it has to be a sustainable part of the commitment to the health system. So really, this has been, there were many bad things that happened in COVID, many terrible things. Far too many people lost their lives. But if there's one kind of silver lining of all those terrible things, it is the fact that it has triggered this extraordinary change in the availability of medical oxygen that is already saving many people's lives, and will continue to do so, and will continue to help protect people better from the threat of new respiratory pathogens. So huge thanks to the government of Kenya, and also thanks to you all, because this has been complicated and difficult and very stressful, I know, at many points in this journey. Philippe and I are friends and partners, and it's been even this has been quite a sort of bumpy ride we've navigated together. But I really do think it's worth it, and it's all the more worth it if we continue to step up our investment and commitment. So thank you.
Thank you very much, Peter, for making time at this event. Thank you for your leadership, and thank you for the Global Fund's leadership on this really critical issue. It gives me great pleasure now to invite one of the co-chairs of the Global Oxygen Alliance, PAHO, to come up and speak. And we have Dr. Rhonda Seeley-Thomas, who's the Assistant Director of PAHO, who's going to come and make the next intervention. Dr. Thomas is a national of Antigua and Barbuda, and before her current role, she's held several positions in the health sector in Antigua, including Medical Officer of Health in the Ministry of Health and other departments. We thank you so much, Dr. Seeley-Thomas, for PAHO's leadership in GOAL, and we look forward to your intervention.
Thank you, Chair, and allow me to adopt the protocols that have already been extended. And as Assistant Director of PAHO, I am so pleased and honored, and I thank the government for inviting me. And we're also pleased as PAHO to be co-chairs of the Global Oxygen Alliance. In the region of the Americas, we have done several things with our member states in order to improve oxygen therapy in hospitals and in other healthcare settings. Firstly, in 2020, we established an oxygen technical group as part of the COVID-19 response to provide technical cooperation for managing medical oxygen surges in our member states and to increase oxygen therapy needs amid various constraints. And Minister of Health of Guyana, because Guyana is one of our member states, he outlined some of the challenges they faced in Guyana, and this is some of this is very similar to what other countries in the region of the Americas also faced. This group adopted a holistic approach, enhancing clinical care for health systems and services and providing technical operational support. Even beyond COVID-19, that group continues to function because, as would have been mentioned before, oxygen is critical in many healthcare settings, in maternal mortality, asthma and other chronic conditions, heart attacks, violence, trauma, which are things that plague countries of the Latin America and the Caribbean. The second thing is that since the adoption and in keeping with the WHA resolution in 2023, PAHO has developed tools to facilitate situational diagnostics at both health systems and healthcare facility levels. We have also published several technical documents with recommended best practices for the rational and effective use of oxygen and supported the acquisition of oxygen generating plants and oxygen therapy support devices. In PAHO, we have a virtual campus for public health, and we have developed virtual and face-to-face training sessions in oxygen therapy that have benefited over 13,000 healthcare professionals, with course materials available in English, Spanish, French, and Portuguese. We've recently joined the WHA Academy, and we hope that we can extend this virtual campus accessibility to other regions as well. Thirdly, and more recently, representatives from 9 of our member states from Central America and the Caribbean, as well as PAHO itself, participated in WHO's National Oxygen Scale-Up Framework meeting that was mentioned earlier that took place in Senegal. There, our member states shared experiences and discussed unique challenges in developing national roadmaps to improve oxygen access. PAHO will work with our member states not only in finalizing those roadmaps, but also in its implementation. While significant progress has been made in our region, we acknowledge that much work needs to be done. You can count on PAHO, Pan American Health Organization, to further advance these efforts, since we recognize the importance of actively contributing to the collective efforts by advocating for proactive actions and prioritizing patient care. We understand that the challenges we encounter in the Americas are also experienced by other countries and regions, and that by sharing experiences and resources, it is crucial, they are crucial for achieving our primary objective to increase equitable access. We realize as well that it is imperative to operate in a cohesive manner, guided by common guidelines, strategies, and tools. As we move forward, our focus remains on continued collaboration to achieve our ultimate goal of increasing access to medical oxygen for all patients in need. Thanks once again for this opportunity, and we look forward to continuing our work with the Alliance as we move forward to improve oxygen access. Thank you.
Thank you so much, Dr. Thomas, and again, thank you for the leadership of PAHO on GOAL. I'm now going to invite the other co-chair of the Global Oxygen Alliance, the Africa Centers for Disease Control. And we have with us here Dr. Mohamed Abdelaziz, representing Africa CDC today. He is the Africa CDC Head of Disease Control and Prevention and the Acting Head of Surveillance and Disease Intelligence Division. Thank you so much, Dr. Abdelaziz, and thank you again also for Africa CDC's leadership and support. Over to you.
Yeah, really, thank you, Chair, and thank you for having us. I will speak on behalf of the Director General of Africa CDC, Dr. Jean Kaseya. But before then, let me say that as a medical student, a medical doctor, if you practice in Africa, you must have seen a child dying of pneumonia needlessly because you've run out of oxygen cylinders. I mean, if you've practiced in Africa, you will see that surgeries cannot be performed, even emergency surgery, because the hospitals where you are working, they do not have oxygen. And as a house officer, I remember one of the things I did most was to run around and check canisters and whether they have oxygen or not. That's not part of my responsibility, but you cannot, your senior doctors cannot operate if they do not have the assurance that you have that. Well, when I left clinical practice, I forgot all about that. I thought I was not going to see that until the COVID-19 pandemic came. And at that time, I was supporting Nigeria in the response. And we saw many, especially in the treatment center. I have a very personal story in which one of the person that I know very well, and he knows I was taking part in the response, was begging for me to just help him get oxygen cylinder, just to give him air. And he died the next day because that was not available. Even during COVID, because of the demand by the COVID patients in the treatment center, most of our hospitals could not. At that time, Africa CDC had to do something. So we're working with the Ethiopian government. One of the things that the Ethiopian airline was distributing all over Africa was oxygen concentrators. I remember picking many at the airport for the different treatment centers in the country that I was supporting. So I know Africa CDC has been working very closely with this initiative, but there are, learning from that experience, there are things Africa CDC is doing now to prepare for the next pandemic. And one of those things, it's not just oxygen we noticed. We noticed local manufacturing of health commodities on the African continent. It's not compatible with pandemic, preparing for the next pandemic, in a situation in which 90% of what you need immediately to respond to either an outbreak or a pandemic is brought from outside the continent. That is not compatible with what we're doing. And that is why one of the flagship initiatives of the DG of Africa CDC now is local manufacturing of health products. And oxygen, initially we started with vaccine, but we've expanded now to all health consumables. Oxygen is something that you need to manufacture where it is needed. And because you don't need a very long supply chain, lives are involved. It's usually, like Peterson said, in critical condition. All of them are in critical condition. If you ask for oxygen, you know the person needs it immediately. So we are working through various mechanisms, the workforce that is required, the technology that is required, and even the markets and the demands to see how we can put all of this together to ensure that commodities like oxygen, the kind of challenge we had where it was almost non-existent in some countries during the pandemic. We do not see, and countries need to supporting countries and talking with countries to build the capacity in terms of manufacturing. And we've seen some of our countries are making great progress. One example is Rwanda in getting to the target where they need to be. Again, one area that's required, I mean, we just have to do it, is financing. We need to put in money. Partners are bringing money, but we also know that domestic financing for oxygen is the more sustainable way to go. And that is why part of what we are pushing and strongly advocating at the highest level is for African countries to meet their own obligation of spending 15% of their budget on health, and part of that should go into the preparedness, which also entails that we build our capacity to manufacture oxygen as at when required. Critically, we know that to make any health system change that is required to support a system that can provide oxygen at a hospital 3 minutes at the time of demand, you require very strong national public health institutions. Strong national public health institutions that can work with different partners to make the change, because it's not just the manufacturing, and we also need to have some health system change that allows for these critical life-saving resources to be able to reach those who need it at the time required. So strengthening national public health institutions is one of the key areas that Africa CDC will support this agenda in the next, preparing for the next pandemic. Not just the next pandemic, but again, let's not forget that people, as we speak, will require oxygen. And this is not an investment that you do, that you say you're waiting for the next outbreak of pandemic. This is an investment that you do and you continue to use it. And as you're using it, you are preparing yourself for the next pandemic. And if you have a facility that produces oxygen, people need it and it dies, and you don't use it, then it means you're not preparing for the next pandemic. And I tell you, we all know that when we have outbreaks and pandemic, people will require oxygen. Finally, Africa CDC believes we cannot do it alone in Africa. So building action-oriented partnership like what we have today is the way to go. And we cannot begin to build this partnership at the time we need to expand rapidly the supply of oxygen. No, we need to build this partnership now and work in a way that the capacity is there to rapidly expand at the time that is needed, and use, I remembered my previous DG used to say, what you need in future, use it now, so that when you're using it, when the time comes for you to expand, you already have a system on ground. So if you do not have what is working, then we cannot think of doing that during crisis period. Thank you, and it's an honor for me to speak here.
Thank you very much, Dr. Abdulaziz, and for reminding us that the best way to prepare for future pandemics is to invest in the current endemics we're fighting now and position them to surge for that response. We have two more speakers before we go to closing remarks, and so it brings me pleasure to invite one of the Secretariat agencies of GOAL, which is UNICEF, but also an agency that has led at the forefront of oxygen access even before the pandemic, during the pandemic, and now is part of GOAL driving that agenda. So we have Dr. Fuzia Shafiq, who's the Associate Director for Health at UNICEF in New York. And she is responsible in that capacity for focusing on many different aspects, including maternal, newborn, child, and adolescent health, primary healthcare, health system strengthening, and many others. Her extensive work includes leading UNICEF's health program in Afghanistan and also the health and nutrition program in Yemen. Thank you, Dr. Fuzia. Over to you.
Thank you, Robert. Excellencies and esteemed colleagues, a very good late afternoon to all of you. For those of us who've been in Geneva since Sunday, I'm sure you've sat through many, many sessions where we've been talking about what a difficult world we live in, with all kinds of challenges, from conflict to multiple crises, to climate change and its challenges. So maybe I can start with a positive story. Up until November last year, I was leading UNICEF's health program in Afghanistan. And one of the things that I look back at with a lot of pride and satisfaction is the work that we did on oxygen. Indira Gandhi Hospital in Kabul is one of the country's largest maternity and the largest pediatric hospital. And up until the installation of an oxygen plant there in mid-2023, it relied on very unsteady, unreliable, and inadequate oxygen support, despite the fact that it is the largest pediatric hospital in the country. So it's important that we count our successes, be they large and small. At UNICEF, we recently did a survey to see what we've done, both as part of this partnership, but also in the 2 years before the partnership came together. And not to go into a lot of figures, but of the 100 countries that UNICEF and partners have supported over the last 3 years, so far we have responses for only around half of them, 50 of them. But even these responses show that some 24,000 health workers were trained and capacitated to be able to use oxygen. And over 6,000 health facilities have access to oxygen due to the work that was done in the last 3 years. If we look at just 31 of these 50 countries, around 23 million children who did not previously have access to health facilities oxygen supplies now do. And we are very excitedly looking forward to getting all the figures so that we can, together with you, celebrate the successes that we've had in the last year, especially, but over the last 3 years. Now, of course, when you engage in things like this, there are challenges. We've had our share of challenges in the oxygen work, some of these unforeseen. And we are, based on the experiences of our country teams, looking at how we address some of these challenges. And of course, they range from having difficulties around not having equipment that is climate friendly, or having equipment that is extremely expensive. And so we've been trying to, with all of you, address some of these challenges. So looking at things like solar energy as an alternate energy source, looking at equipment that is more conducive to providing services in these places, like the low resource setting adaptable oxygen concentrators, or looking at energy recovery through heat exchangers. In addition to that, also looking at private-public partnership to see how we can bring in both financial and operational sustainability to the work that we've been doing. Now, within the partnership, and I'm glad that several of the speakers spoke about this, at UNICEF, we are fully committed to the partnership. Our interest, of course, is mothers and children, and we look at it as a dividend of the COVID experience, as horrible as it was, that something for which we've been calling attention for the last few decades, around how many children's lives we could have saved if we had oxygen in the previous years, and did not have either interest or the funding for it. One of the dividends of COVID is that now we do have both interest and financing and the capacity to do that. And it is for this reason that UNICEF is very heavily invested in the partnership, and of course, adding to that the ability to be better prepared for any future emergencies. Two things, and with that I will end. One is that at UNICEF, and I know many of you, we do not see oxygen as a commodity only that is to be supplied. As Christopher, my colleague who leads the work with our supply division, likes to say, procurement is the easy part. It's getting the equipment there, getting it installed, making sure that we are able to operate it well, that we are able to maintain it well, and that it's surrounded by people who can use it so that we get the best out of it. That is the most important bit. So we see oxygen very much as part of an ecosystem. It's not just about hardware. The software is just as much, if not more important than the hardware. So maybe I can end with an ask, which is that we understand that the need for the oxygen is here, and what we have right now is probably down here. And yes, we need to bridge that gap. But what is even more important is that we've managed to get a lot of supplies out there, but those supplies are not being used to the best of their ability. And so we also have to bridge that other gap between all the supplies that are out there and their optimal use. So investment in making sure the health workers are trained, that the countries have the capacity to maintain and operate these supplies and get the best out of them. So an ask to the partnership, and we'll continue to engage and deliver. Good luck to us all. Thank you.
Thank you very much, Dr. Fujia, and thank you for reminding us that, you know, our first priority is to ensure we realize maximal impact from the $1 billion that was raised during COVID, as we go and aim to raise the additional 4+ that will be needed to get us where we need to get to. Our last speaker before we have closing remarks is a dear friend, Maureen Morenga. She's the Executive Director of the Lean On Me Foundation. And in her capacity today, she's a communities delegation representative to the board of Unitaid, but also on the Global Oxygen Alliance. Maureen is a passionate advocate for health, development, and rights of women and children, and her passion for advocacy is driven by her lived experience and the inequality and vulnerability that young women and adolescent girls experience in her community and in the communities that she supports globally. She founded the Lean On Me Foundation, an organization that supports the health services for women and children. And we really welcome you now, Maureen, to share your thoughts here. Thank you, Maureen.
I'll stand on the existing protocols already observed here. Ladies and gentlemen, good evening.
Good evening.
It's really difficult to speak after the science has happened here. You know, there's a lot of scientific science that has taken place here. And then I come from the community, but like he said, I leverage my lived experience to do advocacy. So, Honorable Nakumicha, I was part of the group that was there when the many lorries of oxygen cylinders were being flagged by the president. I was representing KCM. So I saw it happen, and I was very excited because 19 long time ago, in the early 2000s, when I was diagnosed with HIV, there was no treatment. And when the doctor told me, due to my pregnancy, I would live for 6 months, someone gave me a substitute. They told me, you know, I got a group of people who were living with HIV, and they told me, you know what, you can hack this. And the way to hack this is that if you're sick, you get treated. If you feel, you kind of manage any condition that would get you down. Just make sure you don't get down, because when you get down, it's hard to go back up. So at least I had a substitute. I used to make sure I don't get down. When I'm sick, I quickly treat the symptoms and the opportunistic infections. And then I had my baby. But what I learned with COVID is that there's no substitute for oxygen. When you need it, and you need it right away. And you cannot be given another formula. With the HIV, Dr. Sirengo would give us formulas to survive as we waited, hopefully, for treatment to come. And then finally there was treatment, and here we are. But when I had COVID in 2021, first of all, I didn't know I had COVID. I wasn't sick, because the symptoms I used to read on those placards read coughing, chest pain. You know, there were some things someone was supposed to feel in their body. But all I felt is that I was tired. And my son told me, Mom, you know you're fat. And fat people get tired really quickly. So you need to, he didn't even say I added weight, he was using the word fat. And you need to do exercise so that you can stop feeling tired. And so one day he told me we need to have a walk. And we walked for some distance, but I couldn't come back. So I took, we call them boda motorbike, to bring me back home, and said, you'll always feel tired. You see, you cannot even walk. You have to work. So his concern was my weight. And then in my community, you don't just, tiredness is not sickness. So you cannot stop going to work because you feel tired. You have to carry yourself to work. So I used to carry myself to the office. And I remember one time we had a virtual meeting, because we had some lockdown periods, and we had a virtual meeting, and someone told me, I heard you wheezing. Are you okay? So someone called after the meeting, and they said, Maureen, I heard you wheezing when you spoke. Are you okay? And I said, I'm okay, just tired. Another thing we were told is that you will lose sense of smell. So I thought my nose would be blocked, you know, in some way so that I can't smell.
because I wasn't smelling anything, and that is not, for me, it wasn't like I've lost sense of smell. In this room, you can't hear any strong smell, so you wouldn't know if, yeah, if you've lost sense of smell or something. So I didn't notice until one time when the onions were burning and someone was saying, "You didn't hear them burn?" And I'm like, "Burn? The smell of burning onions?" No, I didn't get that. So I realized maybe I'm not well. So I managed, and when I went to hospital, they did the nasal swab. It was negative, so they gave me malaria tablets because I had traveled from Nairobi to Kisumu, and I did my malaria treatment. But whenever I do malaria treatment, within 2 days, I'm usually well. But this malaria this time was taking too long to recover. So I went back, and I told them I'm having difficulty in breathing. I'd started feeling that, and I had had pneumonia before. So I told them I'm feeling pneumonia-ish. And you know, that time we had an outbreak of COVID, and the hospitals were full. So we were going to the lower level hospitals. And I told the doctor, I'm feeling pneumonia-ish. And they asked me, so have you had pneumonia before? I said, yes. So what do you do when you feel pneumonia-ish? I said, there's this drug that I'm usually given. And so I was given that one. So I went back home and took that for a while, but my condition worsened. My son got concerned that I wasn't getting out of bed. So he went and called my cousin and said, you know, Mom has been sleeping for 2 days. She has not taken shower. She hasn't gotten out of bed, and she's saying she's not sick. So when this one came, I just said, I think I'm tired, but can't you let me finish the medicine I was given? You know, because you don't want to walk. You feel you have no energy. You feel people are disturbing you and they're telling you to go to hospital. So by the time they dragged me out of that hospital and I had a PCR, I actually had COVID. And my oxygen levels were very low. I needed to be on oxygen urgently. Unfortunately, there was the public hospitals were full to limit. I needed to find another hospital, a private one. The first one we went, they told us the minimum deposit we didn't have. And they advised the people who were with me that she doesn't look so good. Try find her somewhere to get help because she doesn't really look good. So we went to a different private hospital. We also tried to negotiate with the amount of money we had, but they still couldn't admit us. But now, one thing they said is that, can you see how she's snoring? She's awake, but we can hear her snore from the gate. You need to find her help. She'll die in your hands. So in the third hospital we went to, it was a faith-based hospital. They quickly took me to the ICU. I couldn't remember what happened until later when I came back from the coma. So what I learned was that the only time I got alarmed is when I couldn't, I kept telling people, open the windows, can I get something to fan myself? Because I couldn't feel like I'm breathing properly. And I felt like I'm panting. I'm trying to get some air. And I remember when we were young kids, we used to play a game where you'd hold your breath for a while to see who could hold their breath even longer. I didn't know that was an exercise because as I was recovering, I used to be asked to do some breathing exercise, some of which involved holding your breath and that shows how urgent oxygen is. Because apart from moving from hospitals, I had a very strong social network, both within the country and globally, that were fundraising. They had, oh, she's in an emergency. She's not looking too good. Some people would take photos of me and share, she's not looking too good. This is her. And we are losing her. We need this money to get her to get her oxygen. And one of the most traumatic things is that while I was being sent away, I saw others who were also being sent away, and they look worse than I did. It hits, every time I think about it, I know some of them did not make it. I know there are people who died. Another traumatic experience was that whenever we were in the ward, we would go to bed 10 people. When I'd come from the ICU, now I was in the recovery ward. People would be brought in. It was a very high season for COVID. People would be brought in and we would go to bed 10 people and wake up 4. So it wasn't obvious that you'd wake up the next day. And some of those who died they looked a bit more stronger than I did. And so it got me really scared. I had to stop. I had to always keep my curtains closed so that I don't create relationships with the people around, because you created relationship with someone and then they started breathing funny and And sometimes the doctor said they brought her too late. They should have brought her earlier for the oxygen therapy. And so it really hit my mind that I have lived years with epidemics that were called life-threatening, but there is nothing as urgent as oxygen. 25 million lives is too many lives to be losing every year because of oxygen therapy. And I've had a lot of conversations around primary health care, universal health coverage. I think we need to ensure that even in the discussions of primary health care, we talk about how do we administer medical oxygen in this platform. Kenya has a fantastic program on community health promoters. If they had those pulse oximeters to actually test people's oxygen levels, then we'll have fewer people going to hospital very late and losing their lives. So I think these are some of the things we can consider. And then the HIV response has taught us as communities to fight. Initially, when we used to get tested, you'd go for a HIV test and it would take 2 weeks for you to get your results. You go home and you start thinking of many things. Like me, I was tested 5 times with 5 different names in 5 different hospitals because I didn't trust this one. So you can imagine every time I waited 2 weeks for the result and then I said, positive, that's not me. Let me go to a better hospital. And then I take a test there with a different name. And then 2 weeks like that. So, but we fought, and nowadays we have self-test kits. You can actually do the test at this. So we are also calling for point-of-care tools for medical oxygen, where people can receive it at the nearest spot of healthcare. And I know it's doable. If they brought self-test kits, I'm sure those years, if you told them, there'll be a time when I can test HIV like I test pregnancy in the bathroom, they would have said no. But we're doing it, aren't we? And then I've had a lot of calls for domestic financing, which is very critical for sustainability. But we also appreciate global solidarity because we are building infrastructure, we are building systems. And so the donors should not close their tap until we are safe enough for the countries to be able to sustain what we have built. So in this process of building and strengthening, we are calling for global solidarity and to ensure that as our governments contribute to medical oxygen, that donors are also helping and keeping their commitments. And finally, strong civil society advocacy is very critical for this one. Just as oxygen cannot wait, advocacy for oxygen can also not wait. And like my colleague from UNICEF said, that if COVID did not hit men, if it was a disease for women and children, I don't think we would have moved this far. So COVID was a bad thing. Some of us almost lost our lives, but we are glad it happened, and it happened for everyone. And we are also glad that even the richest people in our countries could not move out of the country. They had to use the same systems that are within the country because the borders had been closed. And so we are calling for support for civil society advocacy so that we can keep in check all these commitments you're making here. I've noted them down and we need to follow them up. So we need support to do that and to hold you accountable. So the need comes very urgently and we need to be prepared. We cannot start planning when people are losing their breath. So because you cannot stay without oxygen for more than 2 minutes if your lungs are good enough, you know. So I think if you hold your breath now, you will release it before 2 minutes are gone. So I think people cannot wait. Oxygen cannot wait. Let's do it. Thank you.
Thank you, Maureen, for that really powerful testimonial and for bringing it right to us from a lived experience of why oxygen is so important. And also for reminding us that as we look to pursue increased investment in this essential therapeutic and system, we don't forget the critical investments that need to be with the communities, those who have to go and demand, generate advocacy, educate, so that they can educate communities, but also educate policymakers and governments about why this is so important. So as we funders like Unitaid and Global Fund and others program for capital investments, but also human investments such as training and biomedical engineering, we must also fund the communities and the networks so they can be out there demanding for this. And we will definitely commit to do that and are committing to do that. So in closing, it brings me great pleasure to invite Dr. Philippe Dunton to make the closing remarks. Philippe is the Executive Director of Unitaid, my boss. He has more than 25 years of experience in public health across HIV/AIDS, infectious and tropical diseases. He's been at Unitaid since its inception in 2006, and as Executive Director, apart from leading this organization, he led, among others, the Access to COVID Tools Accelerator as co-chair of the therapeutics pillar. And when they came knocking on his door and said, Philippe, we don't know what to do about this oxygen problem all around the world. Can you help? And Philippe has never said no to a complex problem and one that's going to have such impact. And you heard from Dave about the Oxygen Taskforce. Philippe, working with Welcome, the Global Fund and others, WHO stood it up. And here we are today with the Alliance. So I'm really proud to hand over to Philippe to close the remarks and to take us through the last part of this event today. Philippe.
Thank you, Robert. Minister, dear colleagues and friends, it's very difficult to talk after Maureen, I have to say. So I have to, well, it's not the first time you did it before me. So, but yes, I think it was powerful, to the point. Robert mentioned the importance of working with the civil society. It's something that we have learned in my work in HIV/AIDS, but in fact, it's true for everything we do. We are making 3 mistakes all the time in public health. First is we don't really believe so much in innovation, but without innovation, you cannot address what people need. The second mistake we are doing is we are the last sector of activity in the world where we don't really pay attention to the consumer. We talk about the patient, they have to wait, you know. But everything we do now, we receive an email, say, how was the service? How can we improve? And I think that to have that kind of dialogue with civil society makes a lot of difference. And frankly, it's a mistake not to do. Let's be honest. And the third thing is to think that poor people cannot use the tools or the services that they need. It's amazing. For me, I'm still struck all the time that no, you know, the people cannot change the behavior, or they will not have this and this, or they will not understand. That's really stupid and it's untrue. But look, I don't want to make a long closing remark. It's late, we have been up. But there is something that is, I think you have seen. We have, all of us, a personal reason to do what we do. And I don't know all the stories, but we have heard some of them. In my case, I still furious because for many years, we didn't have any treatment for HIV. So I've lost a lot of people under my watch. Working in the South, I lost people dying from malaria because I was not in situation to provide any medicines. I remember my first night shift in the pediatric ward, you know, with premature babies. I was scared to death because the first thing you have to do is to put, at that time, it was not easy, you know, it was big devices to measure the saturation of oxygen and not burn the skin of the babies, by the way, and then give them appropriate oxygen. Frankly, I've not slept 1 minute that very night. So I think it makes the experience we have, makes what we what we want to do. And I think that we should always remember, and I think that you have seen that all the representatives of the organization that forge and make this alliance have expressed why it's so important. It's so important for the people in need. But a couple of remarks building on what was said. Japan said that how important it is for the universal health coverage. And it's absolutely true. It's also absolutely true, that said Peter, that it's not that easy, in fact, dealing with that. It's complex. You need different skills in the country. You need different type of workers, not only health workers. But if we cannot do that, how can we be serious about universal health coverage? It's, I think, one thing important. The second, I used to say that access to oxygen is a no regret move. For the reason you know, Peter said it's a no-brainer. And of course, the fact that we have to repeat that all the time, that yes, we have the experience of COVID. We don't want to be in the same situation ever in the next pandemic that will be, of course, airborne disease at, I don't know, 19%. But I think the fact that on the day-to-day basis, there is a lot of life and needs for access to oxygen is what makes what we do absolutely key. This is important because when people talk about pandemic preparedness, it seems that, you know, sometimes I have the feeling that they are thinking that, oh, we have time, you know, or to build something that may be useful in the future. And I'm really convinced that the best thing we can do, including in oxygen, is to do better the work that we have to do with the country, for the people, every day. So every day we can progress, even if it's difficult. And that's, I think, that's it's the sense that we have in common. So yes, I'm really proud of the team. I would say the teams, but also the team in Unitaid, and Robert and Katie. But also it's really an honor to work with you from WHO, from PAHO, from African CDC. But also there are people who are not in that room. We have NGOs who are working in countries. I cannot make the list, but you know, in Kenya, we have been supporting CHAI for the access to oxygen, and we are investing part of the 82 million that we have invested as Unitaid in that will go to the local production, and in fact regional, because it's Kenya plus Tanzania, of oxygen, aligned with what was said by the African CDC. It is all these things that will make a difference. Another reflection I want to share, because it's, you know, we have to understand that first we need to thank the donor for their support, in particular for oxygen. So the list is quite important. Of course, Germany, France, Norway, and more recently, Japan and Canada. But we need to understand that a lot of these donors will face the wall of the replenishments. I'm not a financial people or a banker, unfortunately, but I mean, it's obvious. And so the fiscal space may not be so easy to crack. So it's about priority, it's about trade-off, it's about also making the point that we can work together. All the time, donors said, oh, it's complex, you have Unitaid, Global Fund, you have UNICEF, PAHO, whatsoever. How you work together? Well, this is it. And it's not just to work together, it's to work also to support the country, to support the people in need. And I think this is very powerful and should be explained better. So I hope, for example, that, and again, thank you for Kenya government and Kenya mission to have us today, but we need to make some more noise, maybe using the G20 or something like that to use what we will have to do is to make the investment case based on the work that you and your team are doing in the countries, making sure that we have the way to measure the progress and measure also the need. This is absolutely key as the next steps and for the future. And I will end on that because, again, it's a long-term commitment. It's not something that we can say, oh, even in a year, we will have work. And we can talk about international solidarity, for sure, it is needed. We need to make sure that the decision at the domestic level can be taken. And of course, we mentioned the role of the government and also the civil society. And the other part of the donors to say, look, demonstrate that you can work together, but also make sure that it's responding to a need and priority from country. It's also, I think, clear. Not today, but that's the reality. And I think that it's a way also to tell the story about what we try to achieve and demonstrate that we change the reality and the real access of people to oxygen. Thank you. Thank you for all the day today, but all the work you are doing every day. And more is to come, but this is the good work. Thank you.
Thank you very much, Philippe. Tomorrow, the members of Goal Leadership and Secretariat will already be getting to work. We're holding a retreat to reflect on this last year and what we have to chart as a course ahead. So we're not just here to talk today about the progress that's been made and the challenges that lie ahead, but we're getting right back to work to push forward. So I'm not going to repeat what has been said by Philippe in closing, but I hope today's session has been enlightening in terms of what we're doing hand in hand over the last year, but the long road ahead of us. But we can only achieve it together and in partnership, and that's what gives us a great deal of encouragement. Now, you heard from the Honorable Minister. She welcomed us here to the mission, which is also this one Kenyan territory here, actually. You can't be welcomed to a house in Kenya without being offered some food and drink. So on behalf of the government of Kenya and the co-hosts of Go, we are very happy to invite everybody outside for some refreshment. We did a bit of a sun dance. The sun hasn't come, but the rain has stayed away, which is great. So we do have food and refreshment. Before we do that, we do want to take a group photo. If the Unitaid team and the mission team can shepherd people outside, and we'll get people ready for the photo, and then we can unwind over some food and drink. Thank you so much. Thank you.